Hello everyone, welcome to Osteoporosis Canada FLS Works webinar series. We're going to get started in a few minutes. In the meantime, you should be able to see a screen that's in front of you, and we will start right on the hour, so I'll let you know when we get going. Hello and welcome to the FLS Works webinar series. We're from Osteoporosis Canada. Thank you for joining. We're just in hold mode here for a few more minutes until we get reach 1 o'clock or 12 o'clock, depending on where you are. and then we'll get started. So thank you all for joining. Hopefully your technology is working fine. If you have any issues, please just send me a note via the chat message if you can't hear us, and we will try and correct that. Okay, so thank you everyone for joining us at Osteoporosis Canada FLS Works webinar series. We are being joined today by Dr. Bill Leslie, and I'll introduce him in just a moment. If you have any technical issues, please just send me a message on the chat box. If you have any questions, you can also use the question box at the bottom, and we will monitor that during the hour and also leave some time at the end to have those questions answered if they come in. As well, if you haven't looked at our website for Osteoporosis Canada and the FLS Hub, please feel free to visit it. There's a wealth of information there, including toolkits, a registry that lists the 46 FLS sites that we have in Canada. We also send out a regular newsletter, and we're more than willing to support any sites that are hoping to start a new FLS. Many of our resources are also available in French, so we try to have bilingual resources available, and we also regularly conduct webinars. This is a listing of some of the services that we provide, as well as you can see the map that you can find on the website as well that will list our FLSs. So today we are thrilled to be joined with Dr. William Leslie, known as Bill Leslie. He is joining us from Winnipeg, Manitoba. And he is a professor of medicine and radiology at the University of Manitoba, and he has over 400 peer-reviewed publications. His research interests are in fracture risk management, osteoporosis testing, and other nuclear diagnostic techniques. He is past president of the International Society for Clinical Densitometry. He's the past chair of the Osteoporosis Canada Scientific Advisory Council, and he's co-led the 2010 Clinical Practice Guidelines in Osteoporosis. He's a director in the Manitoba Bone Density Program and a co-director in the Winnipeg PET Imaging Center. So we are thrilled to have him here today, and I'm going to turn the screen over to him, and you will hear from him for the next few minutes. Again, let us know if you have any questions, any technical issues, and I will try and sort those out in the background. Thank you, Dr. Leslie. Welcome.
Well, thank you very much. It's my great pleasure to be here, and I just hope that you can see my slides now.
I can see them. I hope everyone else can too.
Good. So with that, I'll launch in and let you know that I love speaking about fracture risk assessment, and hopefully we'll have some discussion time at the end, because this is really critical to management of the osteoporosis patient, and particularly to the post-fracture patient, as we'll talk about momentarily. So with that, I'll leap into things. These are my disclosures. I have none. My intent over the next short while is to talk about fracture risk assessment, how this has evolved over time, and in particular since the publication of the 2010 guidelines, and look at some of the recent advances that will help you to improve quality of patient care. This is a reminder of the scope of the problem and the numbers of osteoporotic fractures that we see in Canada in a single year. Approximately 140,000 dwarfs the number of admissions for heart attack, stroke, and breast cancer combined. So this is an enormous problem, and of course, you know the scope of the problem begins with hip fractures, but vertebral fractures, forearm fractures, pelvic fractures, other fractures contribute to the huge population burden that we confront. And when we use the term osteoporotic fracture, or some people use terms like fragility fracture or low trauma fracture, we're really talking about the same thing. We're talking about fractures that occur with simple injuries, minor falls, fall from standing height or less, or sometimes with no direct injury, simple coughing, lifting, bending. And in the case of vertebral fractures, of course, many of those are discovered when there are x-rays of the spine and may not have been noticed previously. And this is just a picture of a forearm fracture, the typical Colles type fracture that affects the distal radius of the wrist. For this definition of fragility fracture, it's important to exclude the ones that don't really qualify as osteoporotic fractures. Those affect the face and head, which is usually direct injury, trauma, fingers, toes, ankles. These are really not considered osteoporotic fractures because they don't increase with age, they don't correlate with low bone density, and don't predict the important osteoporotic fractures like hip fractures that have the greatest health consequences to the population. And these are some of those consequences which you're all familiar with. Some fractures lead to hospitalization, particularly hip and pelvic fractures. There may be loss of independence with institutionalization, death. Of course, you're aware of the fracture cascade, and one fracture predicts another, and so increased risk of subsequent fractures. And we're hoping to intervene to prevent that cascade because of their adverse effect on quality of life and their enormous cost to the healthcare system. And this is a picture of a spine X-ray vertebral fracture assessment scan showing a severe vertebral fracture here. And we're going to come back to this particular case because it helps to illustrate some important points. I mentioned the increased risk of death, and this summarizes that. These are data that we published from Manitoba in almost 50,000 women and over 20,000 men after suffering different types of non-traumatic fractures. And this looks at the relative risk for death. And for hip fractures, you can see that a woman in the first year after a hip fracture has twice the risk of death, whereas a man has almost 3 times the risk of death. Other fractures, spine fractures, humerus fractures, also increase risk of death. The only one that doesn't is the forearm wrist fracture in a woman. But even men with forearm fractures, you can see their risk for death is increased about 1.5-fold. So that there are a lot of consequences to these fractures above the initial pain, of course, that they produce. And you're aware that we don't just have a care gap; we have a care chasm. If you look at the difference between post-fracture management, and this is considered by some a bone attack, and compare that to heart attack management, people admitted to hospital are discharged usually on a handful of medications to reduce their risk of a recurrent heart attack. It would be criminal to send somebody out of hospital without further prevention. But that is a routine care in the osteoporosis patient, where less than 20% of people are receiving appropriate secondary prevention after a primary fracture event. And of course, that's where you come in so importantly. This looks at that care pattern and the percentage of individuals in Canada who receive osteoporosis medication 1 year following a major fracture. And this is Canada-wide, nationwide data, women at the top, men below, looking at the percentage receiving treatment over the last 15 years. And you can see that things did improve from about 20% in women, 10% in men, which is pretty bad. It got up to about 26% and 17% around 2009, and then it's been downhill since then. So that, in fact, we're not doing better overall in Canada. We're doing worse, and there's been a significant decline in the number of individuals receiving secondary prevention following an initial fracture. And patients are aware of that. They're demanding better care. And this is the Osteoporosis Canada Bill of Rights, which highlights the call to action and the demand that all Canadians, wherever they live, have a right to effective bone care and fracture prevention programs. So now we'll turn to the Canadian Practice Guidelines published in 2010. And the focus of those and how they changed from the guidelines in 2002 was an increased focus on the importance of fragility fractures and attention to the care gap that exists in the individuals who are at high risk and the lack of care that most of those receive, in particular those people that have had previous fractures. Bone densitometry has been an important tool in the battle against osteoporotic fractures, and these are data that we published that looks at the BMD T-score, which is you're probably well aware, helps you to categorize individuals as having normal bone density, osteopenia, or a so-called low bone mass, or osteoporosis when the T-score is minus 2.5 or lower. And as one would imagine, as bone density gets lower, it goes from 0 to negative to very negative to less than 3.5, the risk of fracture progressively increases, and it increases exponentially. And so the individuals at low risk have normal bone density, as you can see here, but not zero risk. Some people still fracture even with normal bone density. Osteopenia has a higher rate of fracture. Those with osteoporosis, of course, have the highest rate of fracture. But the problem is that most of the fractures in the population actually don't occur in the individuals who have the lowest bone density. And that's because the numbers of people with extremely low bone density in the population is small. The older population very commonly has bone density in the osteopenia range. So if you put these bars, which is the numbers of fractures in the population, these are the numbers of fractures in the yellow bars, you can see most of the fractures occur in the individuals in the minus 1.5 to minus 2.5 in the osteopenia range. And so our previous fixation on BMD-T score minus 2.5 was doomed to miss the majority of people who actually sustain osteoporotic fractures. So that's why we've moved beyond BMD alone in the assessment of fracture risk. How good have we done? Well, we're still not doing well. These are data we just published recently that shows that physicians and clinicians are still driven by the BMD-T score in most of their decision making. So that the study showed no change over the last 10 years in treatment initiation. Disappointingly, even individuals who are high risk, so these are high fracture probability, vertebral fractures, hip fractures, multiple fractures, individuals that would qualify for treatment, so these are 3,000 women who qualified for treatment, their chance of receiving treatment was 50-50. They got treated if they had low bone density in the osteoporotic range, very unlikely to receive treatment if they had osteopenia, even though they had hip or vertebral fractures, even though they're high risk. And if they had normal bone density, very, very few were treated, even though, again, we selected the individuals who were at highest risk. What about a high-risk fracture? Did that make a difference? And again, these are vertebral, hip, and multiple fractures. The answer is no. People did not treat those any differently than the people without the major fracture. So we have a long ways to go. Lots of education, lots of care to be improved. This is the guidance from our 2010 guidelines, and you can see that following initial BMD testing, and there are criteria for that, there's an assessment of fracture risk, and we really want to draw attention to the higher risk population. Those are individuals whose 10-year risk of fracture is greater than 20%, and we'll talk about where we get that from, or who have already shown that they're high risk because they've suffered a hip fracture, a vertebral fracture, or more than one fragility fracture. That's where we have the best evidence for benefit from treatment, and those are the individuals we really, really don't want to miss when it comes to post-fracture care. How do we assess fracture risk? Well, we have two tools in Canada. We look at the 10-year risk of a major osteoporotic fracture. So this is the percent risk over the next 10 years of hip, a spine fracture that's clinically painful, a forearm fracture, or an upper arm, shoulder, or humerus fracture. And we have available to us two similar and both well-validated tools, the FRAX tool for Canada, as well as the CAROC tool. And I won't tell you what the whole acronym stands for, but just to let you know that this is a tool that was worked out with radiologists and Osteoporosis Canada many years ago. And either of those tools is featured as suitable for clinical use in the 2010 guidelines. So we'll talk a little bit about the CAROC tool first. This was first developed way back in 2005, so it's more than a decade old. It's considered a semi-quantitative tool. It doesn't give us a percent risk. It just allows us to group people into categories of risk as low, moderate, or high, where low is an estimated risk less than 10% over the next 10 years, high is greater than 20% over the next 10 years, and moderate is between 10 and 20%. And again, those are the major fractures we talked about: hip, spine, forearm, and proximal humerus. And so we can apply this to men and women over age 50, and we include two other modifiers to that risk, and that's the risk factors of already having had a fragility fracture. So we've defined that. So a fragility fracture after approximately age 40. I'm not married to the cutoff 40, but it's a good guidance because prior to that, most of the fractures are not going to be fragility fractures. Most of them would be high trauma fractures. And the use of glucocorticoids like prednisone at a high dose for more than 3 months in the last year. And by high dose, we say greater than or equal to 7.5 milligram per day average over that period of time. And these two risk factors kick you up one risk category from low to moderate or moderate to high if you have one of them. If you have both of them, then it kicks you up two categories. So of course, if you've got a fragility fracture and you're on glucocorticoids, then you're automatically considered high risk because that's a double bump in your risk. It's easier to show how that works than to actually talk about it. And this is an example of the CAROC tool. There's a table version and there's a graphic version. This is the tool for women that shows the relationship between age, the HIP T-score, and the risk category low, moderate, high. So in the example that I've shown here for a 65-year-old woman with a HIP T-score of -2.8, which is in the osteoporotic range, but just being osteoporotic doesn't necessarily make you automatically high risk. So you can see that in fact at age 65 with a T-score of -2.8, it plots in right about here. She's actually moderate risk, so between 10 and 20% risk. However, if she had had an additional risk factor, a previous fracture, or which she was a glucocorticoid user, then that would bump her up one category, so from moderate to high. So that's how the CAROC tool works. It gives you a low, moderate, high risk classification. In the FLS model, if you've already had a fragility fracture, then of course you can never be low risk. You always have to be at least moderate risk because you already get one category bump up from the prior fracture. There are tools for men and women. They're very, very different. You can see the difference in the shape for women on the left, for the men on the right. That's not a mistake, and we can get into it if you want later, but it has to do with differences in mortality risk between men and women. So you have to use the right tool, of course, for the right gender. The FRAX tool has been around since 2008, but it's very specific to countries. There are actually over 60 FRAX calculator tools on the website. The Canadian FRAX tool was developed back in 2010 and went live in July of 2010, just prior to the publication of the Canadian guidelines. So if you're going to be using the FRAX tool for your risk assessment, you have to make sure that you use the Canadian tool. We developed it using nationwide hip fracture data for 2005, nationwide mortality data for 2004. We didn't have nationwide measures for the spine, forearm, and humerus fractures, so we had to estimate those based upon the rates of hip fractures, and there's methods to do that. And then we validated it before we started using this in Canadians and in the guidelines in over 45,000 Canadian men and women. So this has been a very, very carefully evaluated tool, and it does work as predicted. And this is an example of the differences between the different FRAX calculators. These are not all 60 calculators, of course. You couldn't show all of those, but shows for somebody with age 65, prior fracture, hip T-score at -2.5, so at the osteoporotic threshold, that if you put the identical inputs in and just change the country calculator, you get a different output. And this is the percent fracture risk that you would get in a woman in the pink and in a man in the blue. And you can see that there's a slight difference, slightly higher in a woman than a man, even though you've used the same inputs, and that's because there's a difference in mortality risk between men and women over 10 years. You can see that if you had the same inputs in Sweden, you'd have a higher fracture risk output. If you use the Turkey or China tool, it would be considerably lower. So this is why it's so important to use the correct tool, which in Canada would be the Canadian FRAX tool. These are the inputs that are needed. You've probably already seen these if you've been to the website. You need age, sex, height, and weight. Simple questions. Have you had a previous fragility fracture, parental hip fracture, current smoking? I use daily smoking, not the weekend smoker. Steroid use, as we've talked about, and we'll talk about more about this later. Rheumatoid arthritis, secondary osteoporosis, which you'll see doesn't actually need to be collected. High alcohol use, 3 or more drinks per day. And if you've got it, the hip BMD value, either as the grams per centimeter squared or as the T-score. And importantly, if you're going to use the T-score, you have to make sure that it's correctly calculated. and the correct calculation is based upon the NHANES reference values for women aged 20 to 29. So it's the same reference population whether you're a man or a woman. So FRAX already considers sex in this part of the calculation, but the BMD T-score assumes that you've used the same T-score for calculating in men and women. In fact, CAROC does exactly the same thing. So just to remind you that you have to have the BMD T-score correctly calculated to use FRAX. If you don't have it correctly calculated, you can enter the BMD directly, but it's specific to the type of machine that the scan was acquired on. You press calculate, and the output gives you the 10-year major osteoporotic fracture risk. This is, in this case, 13%, which is what we will use for the Canadian guidelines. We don't use the hip fracture risk. It's used by some countries, in the US, for example, but not in Canada. So in this particular example, which is our 65-year-old woman with a hip T-score of minus 2.8, which was the one we had with the CAROC tool, without additional risk factors, her risk is 13%, which is in the moderate risk range, which is what the CAROC tool told us prior to consideration of additional risk factors. If she did have additional risk factors and you put that into the calculator, prior fracture or steroids, you would find that that would bump her up to 21%, so she would be in the high risk range, which is again exactly what the CAROC tool would have shown you. This shows that when we have done a comparison between FRAX and CAROC and categorized individuals by low, moderate, or high risk from those tools, and then looked at what their 10-year fracture rates actually were, so predicted versus actually observed, we saw that in the low-risk individuals, their risk of fracture is less than 10%, so they are low risk. When we predicted moderate risk, the risk was between 10 and 20%, so they are moderate risk. When we predicted high risk, it was greater than 20%, so they are actually high risk. And we got the same risk stratification using the CAROC tool. So the tools actually deliver as promised. They correctly classify fracture risk. They give the same risk category about 90% of the time. They're not going to agree 100% of the time because they are different calculators, but 90% agreement is very good. So how do they differ? Well, they differ in terms of whether they're full-bodied. So this is the example I like to use. CAROC is FRAX Light. It's got fewer risk factors, a little simpler. FRAX, the full FRAX has got more risk factors, more complete, more full-bodied. It's a choice, a taste choice, basically. Now, people continue to wonder if you did a direct head-to-head, which of them would actually give the best fracture prediction. We did that study, looking at 34,000 individuals over 10 years follow-up. 3,900 of these actually had fractures. We compared FRAX and CAROC head-to-head, showed that when you look for differences, you will find differences. The differences are small. We identified 10 risk subgroups where there were differences between the CAROC and FRAX predictions. In all 10 of those examples, the actual observed fracture risk was more consistent with FRAX than CAROC, so FRAX was a little better. For example, if CAROC said high and FRAX said moderate, the observed was 15.9%, which is actually in the moderate range. When CAROC said moderate and FRAX said low, the observed was actually 7.5%, so it was actually in the low. So FRAX was a little better in those 10% of discordant cases. If you use FRAX over CAROC, it improved risk categorization. Number needed to improve risk categorization was about 36. For every 36 people, FRAX would do a little better job than CAROC. If you were post-fracture, the number needed to improve fracture prediction, so the number needed to FRAX was 8, and a steroid user was 4. So in the FLS situation, maybe FRAX is a bit better tool than the CAROC tool, but again, the differences are overall fairly small. But if you're looking for a broad conclusion, FRAX does improve fracture risk prediction compared with a simpler CAROC tool. That said, it's more important to use a tool well and correctly than to get hung up on which is the better tool, because they both work in the vast majority of cases, giving the same result. So this is where FLS fits in. Really, It identifies the high-risk individual by virtue of prior fragility fractures of hip, spine. Those that have had more than one fragility fracture, of course, are automatically considered high risk and appropriate for pharmacotherapy. In the moderate risk group, fracture assessment is still important because if we know that there are vertebral fractures that we can identify on X-ray or other spine imaging, then that automatically defines you as high risk. So again, good evidence for benefit. It's important to be aware that we have treatments that work post-fracture. This is just one example published in the New England Journal of Medicine, zoledronic acid given after hip fracture. And if given within 90 days after a low trauma hip fracture, it reduced the risk of recurrent fractures and actually, surprisingly, improved overall survival. This is still something debated, the survival effect, but other studies have shown maybe this is a real phenomenon. Of course, zoledronic acid is not the only available therapies. There are many others. I won't go through the list, but we have effective treatments both orally, intravenously, subcutaneously, different forms that can protect against vertebral fractures, hip fractures, and non-vertebral fractures. So we have good therapies, and we know who the high-risk individuals are. It's very important to be timely in our initiation of therapy. And this looks at the importance both of time since fracture and, again, the differences between men and women, and shows that numbers of years after an initial major fracture, you can see that your risk of fracture, any risk greater than 1 shows increased risk. You can see that 1, 3, 6, even 15 years, in fact, we showed out over more than 25 years, a prior fracture still increases your risk of a recurrent fracture. So that risk never goes away. Even if you've been fracture-free for 10 years, you're still at higher risk for something happening in the 11th year. You can see that the risk does go down a little bit over time, but it never goes back to baseline at 1. You can see that the risk for men in blue is higher than for the women in pink, and that risk comes down a bit more quickly, probably because a lot of the higher risk men are dying off. And again, the effect of fractures on death in men is substantial. We've tried to improve the fracture care with just simple letters to physicians in Manitoba, and we showed that compared to usual care in blue, a mailed notification letter to a doctor did improve BMD testing, treatment, and either, but we never got more than about 25% effectiveness, so there's still more gap than care, and so simple notification helps, but it's not the solution. FLS is considered the preferred model, and in fact we endorse that in the guidelines with the statement that case management is recommended as an effective approach to post-fracture care to improve both diagnosis and management of osteoporosis, and gave that a grade of A. More recently, there's been a large systematic review and meta-analysis that has looked at fracture liaison services and identified that these will significantly improve bone density testing, treatment initiation by over 20%, adherence to therapy by over 20%, but most importantly, it reduces the risk of fracture and reduces, in this study, mortality again. This is a concept that will be interesting to see in the future, whether there actually are mortality benefits in addition to the reductions in fracture recurrence. So I'm going to talk a little bit about the importance of vertebral fractures because, of course, you see here, spine fracture makes you automatically higher risk, whether you identify it de novo from the risk assessment or from spine imaging, which could be done in a moderate risk patient. If you identify a vertebral fracture, that automatically makes you higher risk and appropriate for therapy. The problem is that not all fractures are severe. Sometimes they're very, very mild, as in this example from a vertebral fracture assessment to image. Sometimes they're very obvious, but even the obvious ones are not always well detected. Importantly, though, if we do detect them and if it's communicated to the treating physician or the treating practitioner, it makes a big difference. These are data that we just published showing that if you identify a positive vertebral fracture in your report versus negative, it increases the likelihood of treatment initiation in untreated individuals by over 25%. Whether you're low risk, bumps it up, not to 100%, but it kicks it up compared with the usual care by 25%. Same thing for moderate risk individuals, a little smaller effect in the high risk individuals because most of those are already being treated. So it does make a difference to care in addition to predicting higher risk for fracture. So I'm going to talk a little bit about some of the nuances of risk assessment. This is a 70-year-old woman, a case example, a true case. She had breast cancer and she was starting a high-risk medication called a aromatase inhibitor. She had low bone mass or osteopenic bone density measurements, and her FRAX score came in at 31%, so in the higher risk range. And so would she qualify for treatment? According to our guidelines, yes, she's over 20% in the high risk range. She should qualify for treatment. As it turns out, she didn't get treated for osteoporosis, but she did go on to the aromatase inhibitor for 2 years. Repeat scanning 2 years later shows she had an unchanged bone density measurement, still low bone mass, osteopenic, and now her FRAX score was 7%. Well, what the heck happened? How can you go from 31% down to 7% without any treatment? The answer is in the risk assessment. So when she had her repeat assessment, we had no risk factors in the FRAX calculator. You can see all no's down the scoreboard here. The first time around, though, she had said she'd had a prior fracture. Turns out she fell on the ice, injured her wrist, but didn't get an x-ray, so that's probably not a real fracture. She said her parent had a hip fracture, but it turns out it wasn't a natural parent, she was adopted. She said she was on steroids, but in fact it was only the very infrequent use of steroids given with her chemotherapy, so not long-term steroids. And then she previously said she had rheumatoid arthritis, but now says it's not rheumatoid, it's fibromyalgia. So this shows that the risk factors that we collect are really important. They make a big difference to the risk calculation. So we have to get the right information, because you put garbage into FRAX, you get garbage out. Same thing with CAROC. And so the best practices document from the ISCD says, if you're going to use a fracture risk assessment tool, doesn't matter what that is, you better use it appropriately. So we're going to talk a little bit about how to use these tools appropriately. First off, let's look at prior fracture, because we often have to rely on self-report of individuals. How good are people at remembering and correctly identifying previous fracture? Well, the answer is it varies. This is one study that showed that even though you asked women at 4-monthly interval to report their fractures, at the end of the study, and this is the study of osteoporotic fractures, they identified that 18% of the hip fractures, imagine being hospitalized with a hip fracture, were identified by Medicare claims, but patients didn't report them. They forgot about them. How could you forget a hip fracture? I don't know, but they did forget about 20% of hip fractures. The Women's Health Initiative has also studied accuracy of self-report in women and compared that with the medical record and shown that accuracy depends on the fracture site. For lower arm wrist fractures, the agreement is anywhere from 80 to 96%, depending upon how you do the counting, which is pretty good. For ankle and lower leg fractures, again, assuming that close is good enough, 94%, upper arm, shoulder, 95%, elbow, 93%, hip, about 90%. Where it really falls off is for spine fractures and coccygeal fractures. Coccygeal fractures may not even be osteoporotic. Spine fractures certainly are. But you can see that there's almost a 50-50 whether there's confirmation of a vertebral fracture. So I'm very cautious and do not rely on patient self-report for vertebral fractures. I want to get an x-ray report or see the x-rays myself, whereas I can be usually fairly confident that if somebody reports a forearm fracture or an upper arm fracture, that they'll be right most of the time. So we've made mistakes, and these are my mistakes, and how you can help to avoid those. We know that self-reported fractures is variable, so we try to review that from our PACs or get confirmation, especially for vertebral fractures. We don't want to include the craniofacial, hand, ankle, foot fractures. Same thing, sports fractures, stress fractures, high trauma fractures. We know that vertebral fractures are particularly problematic and may be overcalled or undercalled by radiologists, which is a reality that we're still confronting. So we've modified our intake form and tried to be helpful to collect the right information from individuals. What did you fracture? How and when did you break it? Where was the x-ray? So that we can track that information down and be as accurate as possible. Steroids, of course, glucocorticoids are the other input to CAROC. We've seen a lot of mistakes. We've made a lot of mistakes. Injection to joints, that doesn't count as steroid use because that's locally active. Same thing for inhaled or orally active agents that only affect the gut. Physiologic adrenal replacement is also not considered glucocorticoid therapy. A brief use, a few days, couple of weeks, less than 3 months is not major use. Sometimes patients don't know that aromatase inhibitors aren't steroids. They've just been told that these are bad for bones, and they think they're the same thing, but they're not. So we do medication review. We get that self-report. We get people to bring a list of all their medications from their pharmacy or their cabinet when they come for their meeting, and we review that as necessary through the electronic medical record. And we've tried to be more specific on our steroid questioning, asking people to report weeks of use in the prior year and their average daily dose. We give the form 3 weeks prior to their bone density test, so there's enough time for them to look this up and get answers to the questions, and usually they're very good on this. If you're a FRAX user, you can actually do an adjustment based upon FRAX dose. Even though the FRAX input on the website doesn't allow you to change the dose, once you've got your output from FRAX, if it's a very low dose, less than 2.5 milligram prednisone, you can decrease the risk by 20%. If it's more than 7.5 milligrams, you can increase it by 15%. So it makes FRAX a little bit more flexible tool for the steroid user, and we actually do this in our practice. If you're using the Canadian guidelines, we consider use to be use in the last year. If it's prior to the last year, if it's remote use, we don't count it, even though the FRAX website seems to suggest you should. We do not. For CAROC, because it gives a larger effect for each of the clinical risk factors, you have to be over 7.5 milligrams daily to count that as a risk factor. So again, a nuance in the use of FRAX versus CAROC and how you use glucocorticoids. This looks at the some of the risk calculation. What are we looking at here? The relatively normal bone density with a lot of risk factors: previous fracture, hip fracture, steroids, rheumatoid arthritis. That's that individual that I talked to you about that got up to 31%. If you're a FRAX user, you do have to collect some additional information: parental hip fracture, smoking, rheumatoid arthritis, high alcohol. Secondary osteoporosis doesn't change the FRAX score if you know bone density. So even though there's a long list here, we don't routinely collect that because it doesn't change the calculation. So if you actually look at what the arrows show, if you're a FRAX user, you have to collect a little additional information, but it turns out to be not that difficult or time-consuming to do. For parental hip fracture, one important nuance, and we published these data recently, is that the age that the parent is when they suffer their hip fracture makes a big difference. If the parent suffers their hip fracture after age 80, there's no effect on fracture risk in the child, whereas if it's prior to age 80, there's a large increase, 50% increase in major osteoporotic fractures, and also maybe over a twofold increase in hip fracture risk. So we currently limit our use of parental hip fracture to when the parent fractures their hip prior to age 80. How good are people at recalling whether the parents suffered a hip fracture? Well, the answer is good most of the time. They're right. When we've done a direct linkage analysis, they're right about 75 to 80% of the time. Bad news for men. Discordance or incorrect reporting of parental hip fracture is more common with men than with women. Women remember what's happened to the family more than men. Also, the time since the fracture is important. So if the parent suffered their hip fracture in the last 10 years, it's pretty good. Discordance doubles, so inaccurate reporting doubles if it's more than 10 years because memories get foggy. So when we use parental hip fracture, we've made a lot of mistakes. We don't want to be counting hip replacements. That's not a fracture. We don't want to be counting non-hip fractures, osteoporosis without fractures, unrelated parents. Forgetting and changing answers over time is a problem that we've encountered. So we always ask about circumstances and making sure there was surgery, because almost all hip fractures are operated, the age of the parent, of course. And we've modified our wording to try to make this as clean as possible. We don't include fractures after age 80, parents that were adoptive parents, or surgery for arthritis that wasn't related to fractures. Rheumatoid arthritis. People do not report rheumatoid arthritis very well. Most people, if you ask them, will overestimate the likelihood of rheumatoid arthritis. Most self-reported rheumatoid arthritis is actually osteoarthritis. But the important thing is that rheumatoid arthritis gets treated with specific medications. So if we look at the medications, if we don't see that there's one that's typically associated with rheumatoid arthritis, then we tend to discount that and not count it in the FRAX calculation. We also get people to list their health conditions, and if they list fibromyalgia, not rheumatoid, we won't count that. If necessary, we'll even follow up with physicians to offices to verify this in our reporting. If you have an EMR, all the better for you, because you probably have the best source of information. So we've modified our wording, and again, we don't want to be counting osteoarthritis because most patients are not aware that that's different than rheumatoid arthritis. Pitfalls in smoking and alcohol. We don't count the weekend smoker. We don't count cannabis at this point. We know that alcohol is underreported. So there are some challenges in getting this information, but generally speaking, the intake asking about daily smoking is going to be correctly reported. So, a couple quick examples. Here's a 79-year-old woman. She had a left wrist fracture at age 55, fell while curling. Then she had a right wrist fracture stepping off a curb. She has type 2 diabetes since age 50, so for over 29 years. Her father had a hip fracture, but he was 102 years old. This is a real case. So, if we use FRAX without bone density, because we can use FRAX without bone density, no risk factors, the risk would be moderate at 17%. If we counted prior fracture, it would be 28%. If we counted prior fracture and the hip fracture for the parent, it would be 44%. In fact, in our reporting, what I would do is I would say fell while curling. Curling is a sport because it's in the Olympics, and I don't count sports-related fractures, so I wouldn't count the curling fracture. I would count the fracture stepping off a curb. Now, is it from a height? Sure, but that's a curb. That barely counts. That's like stepping off a carpet to me, so I don't consider that an elevation fracture. That's a low trauma fracture. I would count that. I would not count the parental hip fracture because that's after age 80. And one of the tricks, even though diabetes is not an option in FRAX, you can use rheumatoid arthritis as a proxy for the effect of diabetes. And so we do that. And in this particular case, that would allow us to get a risk based upon the prior fracture, based upon the diabetes, and it would be 38% high risk. And of course, you would treat that. Now, that's without bone density. And you can see I didn't count the first wrist fracture, didn't count the hip fracture. If I had the bone density measurement, and let's say the T-score is minus 2.2, then no risk factors, 16%, prior fracture, 23%. Add the parent and fracture, you get it up to 39%. But the way I would report this, using just the second wrist fracture plus the diabetes proxy, it would be 29%. So a high risk range, certainly somebody that would be qualifying for treatment. If you are a CAROC user, you can see that you would exclude the first wrist fracture, exclude the diabetes, because there's no way to use that with CAROC. There's no input for hip fractures with CAROC. You would use this fracture, the second wrist fracture, with a hip T-score of minus 2.2. That's where she plots out in the basic CAROC tool. But now, because there's the additional risk factor of a one fall-related fracture that would kick you up from moderate to high, so she would be a high-risk individual. When in doubt, VFA, vertebral fracture assessment, really helps because that identifies you as being high risk, so that's why this is so prominent in the moderate risk care plan. Unfortunately, when you look back, this is a real case. This is a vertebral fracture, very severe. This person had had a previous CT, previous chest x-ray. That fracture had actually been there for many years and had not been diagnosed on either of these. And so that's one of the problems we have with vertebral fractures, is that oftentimes they're not correctly identified or identified at all. So it's a missed opportunity. That's a work in progress to be able to improve that in the future. So I'm going to quickly summarize here and leave time for questions. Here's my summary for FRAX versus CAROC. FRAX is quantitative. It gives you a percent risk. CAROC is semi-quantitative. You don't get a percent risk, you get a risk category, low, moderate, or high. FRAX is more work, more risk factors to collect. CAROC is simpler, fewer risk factors to collect. FRAX is computer-based, whereas CAROC you can do off a table or a graphic. You can carry it in your pocket. You don't need to be connected to a computer to be able to use CAROC. That said, they've both been well validated, and they're both acceptable for use in the Osteoporosis Canada guidelines. CAROC was widely available and therefore widely used in 2010, so we gave it the nod in the 2010 guidelines. In 2010, you see that FRAX is very widely used and available on much of the bone density reporting software, so it has really become quite acceptable and wide for use. Neither of these tools is perfect. They don't consider falls and other risk factors. You can't include every possible risk factor known to man, so that each of them is incomplete, and where they're incomplete, you need to use clinical judgment. So they both have that as a strength. You can use clinical judgment, and a weakness, you have to use clinical judgment. So none of them is written on stone tablets in terms of risk assessment. You always have to interpret them in the clinical context. So I'll give you my concluding thoughts. First off, osteoporosis is much more than DEXA measurement. I've shown you the importance of clinical risk factors, how you collect those, and that there are some nuances in this that is perhaps not readily apparent when you go to the guidance documents, either from Osteoporosis Canada or from the FRAX website. We do have good tools, even though they're not perfect, and I've shown some of the limitations and challenges in using them. Both FRAX and CAROC are good tools. They've been validated in the Canadian population, and they can be used to improve post-fracture care. And finally, you as FLS coordinators play a pivotal role in identifying the high-risk individuals, getting them effectively treated, and in stopping the fracture cascade. So with that, I think we have a lot of time for questions, and I'm looking forward to discussion.
Thank you, Dr. Leslie. That was great. We will open up the floor. We have 10 minutes. If there's any questions, you can type them into the question box or the chat box at the bottom of your screen. If you find a question that you want to ask later, in a few moments, the survey will show up in your email, and there's a spot there that you can ask a question as well. So we'll give everyone a few minutes to ponder, and thank you again on behalf of the attendees in Osteoporosis Canada, Dr. Leslie, for providing such an informative talk. I'm sure we've all learned lots, and we'll look forward to some questions. So we have a question from Lori, who's asking, should the use of AI affect fracture risk assessment?
So by AI, I assume you mean aromatase inhibitors and not artificial intelligence. But I'm going to tell you that I think artificial intelligence is the way of the future. Let's go back to something more mundane, aromatase inhibitors. We're in the process of publishing some work on this, and we actually have looked at aromatase inhibitors and their effect on fracture risk assessment. To the best that we can see, the aromatase inhibitors do not change the performance of the FRAX tool, so that the output you get, low, moderate, or high, or the percent calculated output from the aromatase from FRAX in an aromatase inhibitor user is correct and is accurate. They are at slightly higher risk of bone loss. The rate of bone loss is increased from about, on average, 0.5% per year to about 1.5% per year. So they do lose bone density more quickly. But the average use for an aromatase inhibitor is 5 years, and 5 years of exposure, that additional loss does not appear to dramatically impact on the performance of FRAX for fracture risk assessment. So currently, I do not make any modification to risk reporting in an AI user.
Great, thank you. Second question, what would you like to see in the 2019 guidelines?
I am on the steering committee for the next guidelines, and I have my own personal feelings about those. What I would like to see is that the next round of guidelines are embraced and widely used in a way that we didn't see as effectively with the 2010 guidelines. As I've shown you, the change in post-fracture care for high-risk fractures from 2010 didn't really translate into a measurable change in routine clinical practice. So I would like to see that the next guidelines address the questions that practitioners have, and that they embrace those, and that it moves the needle in terms of improving care of the osteoporosis patient, post-fracture care, and high-risk care. That's not directly answering the question, because I think there's a lot of details to be sorted out on the 2019 guidelines. But at a broad level, I think that we'd all like to see that those guidelines have an impact on routine practice above what we achieved in 2010.
Thank you. What about the forearm BMDs? Are they of any use?
So forearm BMD measurements are often performed. There are different reasons why one might use a forearm BMD measurement. Again, I'm speaking with perhaps my ISCD hat on, but the Canadian guidelines also acknowledge the use of forearm BMD. Sometimes it's used because an individual has primary hyperparathyroidism. So hyperparathyroidism has a tendency to affect the cortical bone in the extremities to a greater extent than hip and spine. And so there is a recommendation that the forearm might be a more sensitive site to look for the effect of hyperparathyroidism on the skeleton. So we use that, and that's a guidance that comes from many organizations, including ISCD. Occasionally, we have individuals who are so large they exceed the bed table limit. That's rarely a problem with newer scanners, but older scanners may have a weight limit of only 300 pounds, and many individuals would exceed that, and so you couldn't get them on the table to do spine or hip. And so the forearm, of course, then becomes an option, because you can position that on the scanning table and get a measurement. And sometimes it's the only useful site. If there's been severe problems in the spine, degenerative problems or instrumentation, bilateral hip replacements, you may find that the forearm is the only usable site. So those are the situations where the forearm is used. It doesn't appear in the risk assessment determination, as you can see. That is really very focused on the hip, which has been the reference site for diagnosis of osteoporosis and fracture risk assessment from the FRAX group. The only way that the forearm measurement would modify the risk assessment is if an individual is felt to be at low risk using the conventional FRAX or CAROC tool, but they had a very low bone density at the forearm with a T-score in the osteoporotic range, then one of the rules in the Osteoporosis Canada guidelines is that if you were osteoporotic at one of the major reporting sites, that you would bump that up to a moderate risk. But at the moment, that's the only way that the forearm would modify the risk assessment.
Great, thank you. So we have one big question for you at the end, and we'll let you answer it in the next 2 minutes. Despite all the work in Canada so far with FLS and awareness by OC and practitioners, it seems that secondary treatment is the same as it was a decade ago or even worsening. Why is it not improving more, and why is it worsening?
So the reason that it's getting worsening is probably because of bad press, and it's not. I'm not going to call it fake news, but the media latches on to bad news stories, and the rare but true adverse effects of some of the treatments, particularly atypical femur fractures and osteonecrosis of the jaw (ONJ), catches the media attention, and people have overestimated that risk relative to the benefit of treatment. And so this, the peaking of therapy around 2008, 2009, with the decline after that, coincides with when these rare adverse effects were identified. So we're trying to swim upstream to try to work against the bad press. Why are we not doing a better job in closing the care gap? Well, that's because we do not have FLS models in most of the country. FLS, as I've shown you in systematic reviews and meta-analysis, is the single best method for closing the post-fracture care gap, and so we look forward to that becoming standard of care in Canada, and I believe that that will make a change.
Thank you. On that inspiring note, we'll say goodbye. Again, if you have any questions that you haven't had answered and you'd like to put them in the poll, then please do so. And thank you again, Dr. Leslie, for sharing your time with us and your knowledge, and we'll keep up the work with FLS.
Thank you.
Thank you. Bye-bye.